their management. As we all know, whenever we just prescribe one drug along with other drugs or some herbal preparation or any food item, there is possibility that there might be some drug interaction, which may be only increase the response, which may lead to only decrease of the response, or it may cause adverse effect. And here we are mainly concerned when one drug is interacting with another drug, and there we have some adverse effect. So as we all know, the multiple pharma companies are introducing new and new drugs are there in the market. So it's become very important that knowledge and understanding of drug interaction is must for the patient safety as well as the efficient health care. So drug interaction may be between drug and food, and between drug and any supplement, and even drug and the medical condition. So possible effect might be either decrease action, increase action, or adverse effect. And whenever we are giving two drugs simultaneously, if there is some abnormal response, then we should just take care about this drug interaction. So what data tell us that 2.8% of hospital admission are is mainly due to the drug interaction. As we all know, in the adult education we have the polypharmacy, and once polypharmacy is there, that will lead to the severe drug interaction in 1.5 to even 28% of hospitalized patients. And this is data from the abroad in 1999 to 2000. Last 5 years, the deaths due to accidental drug interaction increased by 68%. So that's why this topic, we should take care about this drug interaction. So if we talk about the different type of drug interaction, it may be outside the body, it may be intro, or it may be inside the body. Here we have the drug interaction like incidences and IV, whereas we all that's kinetic and dynamic type of drug interaction are also there. That's the main important one. So drug interaction outside the body might be we all know about the determination of Mittal items. Similarly, amphotericin, saline, precipitated, phenytoin, dextrose, sugar. So thiopentane is succinate. Everywhere, if we combine these two, there are chances of precipitation or inactivation. So we should be careful. Now, important one is drug interaction within the body. As we all know, interaction might be either kinetic type or dynamic type. So here, in kinetic, we all know about all this ADME, and the dynamic part when the action of two drugs interact at the level of cytokines. Now, to just make it easy, we can divide all this drug-drug interaction into different groups. One may be drug which is going to affect the other drug, that affecting drug, or precipitant drug. Or one second group which one is affected, like that's here we use the term object drug. So precipitant drugs are actually responsible for alteration in the pharmacokinetic of the object drugs, because if we are giving rifampicin or cyclin, rifampicin is actually the precipitant drug because it's going to increase the metabolism of your oral contraceptive drugs. So in this way we can divide all these drugs into precipitant drug or object drug, but sometimes precipitant drug may act as object drug, sometimes they may act as a support. So I am just dividing explaining all these things on the basis of pharmacokinetic now. First, which type of interaction are there at the level of absorption? As we know about this, that the antacids, sulfate, all these are precipitant drug here, which can form the insoluble complex with the tetracycline, so absorption will be hampered here. Similarly, reduced absorption of polystyrene will be there once we give the redoxin. Due to the absorption effect, that complex is formed in the polystyrene. So, in this way, if the complex is formed, it can't be absorbed. But in this example, look at PPI, they will just increase the pH of the gastric, and we have some drugs which are can't be absorbed properly in the increased pH. A good example here is bitoconazole, calcium, vitamin, thyroxine. And it's very common practice nowadays. The PPIs are in use with all this, just look at the vitamin with calcium in the menopausal women. Similarly, in the hypothyroid patient, we also use this PPI is usually prescribed. So there are possibility that the absorption will decrease there, so viability will be no more. So what we should do here, there should be gap between. We can avoid this interaction if we give these two drugs at the gap of 6 hours. So that much is, I covered only this part of the absorption. Now I am coming to the distribution part. In the distribution we have two main things, the plasma protein binding displacement, and another is that transport through the this P-glycoprotein. So first about the P-glycoprotein, drug transporter like P-glycoprotein that is there in the luminal aspect of intestinal epithelium cell, blood-brain barrier in the placenta. Here it is responsible for efflux transport. So it will once it is there, if this action is there, it will efflux the drug from once the drug is absorbed. So in the cell, the P-glycoprotein efflux the drugs from the intestinal epithelium, the absorption will be decreased. Once there is activation of the P-glycoprotein in the luminal aspect. Similarly, luminal surface of renal tubular hair aspect of here this drug will increase the systemic drug elimination. So stimulation here will increase the elimination. Or here stimulation in the luminal aspect of intestinal epithelial cell of intestine, it will decrease the absorption. So some drugs which are drugs, digoxin is a drug which is going to eliminated by this P-glycoprotein. As we all know, the digoxin under the neurotherapeutic window. So whenever another drug which are affecting these are drugs which are going to inhibit all this P-glycoprotein. So there are possibility that there will be drug interaction. So let's see the example here. So virapamine, once given with the digoxin, what it will do? It will just decrease the hepatic and renal clearance of your this digoxin. So what will happen? There will be increased digoxin level. So we should be careful once we are giving the virapamine with digoxin. We should monitor the heart rate and ECG of patient. We should look into the digoxin toxicity, and if we need to prescribe both, we should go with the conservative digoxin dosage, and if life-threatening cases are there due to digoxin toxicity, we can use this anti-digoxin antibody. Similar type of interaction is there. Again, itraconazole, protaconazole, they will reduce the renal and non-renal elimination of digoxin, again by inhibiting the P-glycoprotein. So same here we can go with the alternative. This antifungal, oriconazole and vinapine that we can use here, that is not going to inhibit this P-glycoprotein. Again, this rifampicin, it will induce the P-glycoprotein efflux. Now here at the level of your GI, okay, efflux process is there, induce the P-glycoprotein mediated efflux of digoxin in intestine, so that will lead to the absorption part will be important. So level of digoxin will be go down. So here we can go with the alternate. We can this most important part. What we can do is iron filtration. There actually this one is the there. Actually this part is affecting first pass metabolism. Okay. So here we can go with the iron filtration of digoxin, so we can avoid this interaction. Now we have another, this transporter is there, that is mainly in the hepatic region, that if this cyclosporine is given along with all these statins, these two statins, it will inhibit this organic anion transporting polypeptide given that is there. So actually these are there to just uptake this rosuvastatin, fluvastatin at the level of liver. So once we are going to block this one with cyclosporine, it may cause the statin level will go up, and there are chances of this myopathy or this adverse effect to this rosuvastatin. But here we can use the alternate statin, pravastatin can be used if we need to continue the combination. Now we are coming to the drug interaction due to metabolism. As we all know here, the this type of interaction. We all know about the, I have mentioned only some common cytochrome P450, and we all know 3 or 4 is responsible for 50% of phase 1 reaction. Similarly, 2D6, 30%. 2C9, 10%. Why it is reported 2C9? Then look at all these are metabolized drugs are actually have a narrow therapeutic. So whenever any drug is going to affect 2C9, either inducing or inhibiting, there may be chances of drug interaction. So you will find that in the example, that most of the drug interaction are affecting this. Although this one is responsible for 50% of metabolism. So it is also there, we will find some of the interaction in the TA4 also. So just showing the inhibitors of this, all this cytochrome P450, just here 2C9, all this amidrone is there mostly. Similarly, you will find all antifungals are also there, omeprazole is there, some erythromycin, microride, all these are responsible for inhibition of different cytochrome P450 as well. Now coming to the example of, as just look at the warfarin, narrow-therapeutic drugs, metabolized by 2C9 especially. And these are the drugs. All these drugs are just inhibiting the 2C9. So it's obvious that the level of the warfarin will increase. So once more warfarin is there, the chance of bleeding will be there. So here we can amidrone, if we need to go with the amidrone, then we have to taper the dose of, we have to adjust the dose of your warfarin. Otherwise, for these two we have the alternative, raponazole, ticagrelor is also there. For this group of drug, lipidemic drugs, we can shift over to the torba and pravo, which are not metabolized by 2C9, or which are not going to inhibit the 2C9. So in this way we can use the other drugs. Similarly, for antimicrobials, if we give the warfarin with antimicrobials, there is chances of again 2C9 inhibition be there. And it's very important that most of the antimicrobial actually reported to interact with the warfarin. So we should be careful whenever we are going for the warfarin with the antimicrobial. And one more thing, now all the antibiotics kill the bacteria and DIT, which are polycyclic vitamin K. So again, it will lead to the more adverse effect of the warfarin. Simvastatin and amidrone, now here it is 3A4 inhibitor. So amidrone, it will inhibit 3A4, which one is the response for metabolism of these two. Again, chances of increase this status level, this simvastatin will be there. So here we can use the drugs which are not metabolized by 3A4, like this Flova and Buzua, which are many metabolized by 2C9. So we can use this drug, but the amidrone it is must. So here we should take care of all of this side effect with the simvastatin. And here those should not exceed 20 milligram per day with the amidrone. The combination is must. Now all these drugs are again there, which will in why I am putting the list all on the toxicity point. So what these drugs are against 3A4 inhibitor, they will increase. These are metabolized by 3A4, so all levels will be increased. There is possible toxicity point. So we should this contract will be contraindicated. Clopidogrel and omeprazole. Now look here, it is both of these are metabolized to C19. What's happened here? C19 inhibition lead to the active metabolite of clopidogrel is now formed. So we will not get the action of clopidogrel. So here important thing is omeprazole is only this inhibitor. We can use pantoprazole and esomeprazole, which are not going to inhibit this cytochrome to C19. Now that all were the example of your inhibitor. Now inducer, we all know about all these inducers are there. We have all anti-epileptic, some of your antitubercular drugs are also there. So here now carbamazepine, which induce again warfarin, another drug, carbamazepine with warfarin. So chances of induction of this metabolism will be there. If this level of warfarin there, now we have the effect of the warfarin will be handled. So comparatively much more close is the warfarin response. Here what's important is enzyme induction is not a quick process. It is gradual process. So it usually takes several weeks of time to just all these things, so this interaction. So we should monitor for the weeks in such condition. Now coming to the excretion, interaction at the level of excretion part. So here we have the competitive active tubular process are there, just like promethazine and ampicillin and penicillin also, like methotrexate also. We have the 2, 3, 4 degrees and methotrexate will be there because promethazine inhibit the active tubular secretion of this methotrexate. So chances of methotrexate poisoning might be there if we are doing for the antinuclear dose. So avoid the combination. We can promethazine, we can alternative can be used methotrexate for toxicity to monitor. Lithium, as we all know, lithium and dielectric interaction. Lithium, just like monovalent like sodium, that's why they will compete for the excretion at the reabsorption at the level of this PCT. So hyponatremia due to this diuretic will lead to the enhanced reabsorption of lithium. So there are again the chances of lithium toxicity will be there. So we should be careful about the lithium toxicity. Now coming to the drug interaction at the pharmacodynamic at the site of the receptor act. So deoxythiazide, as you all know, the thiazide usually lead to hypokalemia, and in hypokalemia case, deoxy will have the more affinity to sodium potassium ATP, so it will lead to the deoxy toxicity. So here we should use drug which will not cause the hypokalemia, like potassium sparing diuretics, and potassium supplement can just hyperkalemia will decrease this affinity. Now thyroid hormone with warfarin. Actually thyroxine accelerates the depletion of vitamin D dependent clotting factor with warfarin. There are chances of increased warfarin activity. So ultimately bleeding will be there. So as we all know about this also, alcohol with all these drugs which are acting as a disulfide act. So we should be careful there. Want the patient who not take alcohol with this because activation has acid dehydratation. We know all about this. So just summarizing about the food interaction also with drug. The thiamine, like we all know about the chain reaction. We should be careful. If we are using this drug, tetracycline or the chelacin effect, grapefruit juice, and this will be the 340 indicator. We should be careful with the drugs which are metabolized with grapefruit. Omeprazole, it is effective only given half an hour before your meal, so be careful. Food delays or reduced viability or acid, whereas these are this classical kind of. So we should be careful about the drug food interaction also. Drug hub also, aloe vera latex has laxative property, so lower blood sugar also. We should not give this with the oral hypoglycemic agent. Ginseng potassium effect on anticoagulants, anticoagulant, caffeine and oil inhibitors, so be careful. And St. John Wort, this one is now inducer of 3A4, so it may lead to the phototoxicity when used with the tetracycline sulfonamide. Garlic, ginger has anti-platelet effect, so we should be careful once we are prescribing anticoagulant, antiplatelet, it's also screening criteria. So with this, as we have seen that it's really challenging task because number of drugs are introducing day by day. So we don't have sufficient this interaction checker that will, the physician is in a very bad position that how can he just record which drug is interacting with other drug. But we have number of interaction checkers are there, but still we don't have that checker with the comprehensive data of all the new drugs as well as old drugs. So we should keep vigilant against the drug interaction with that drug industry. And one concept is also nowadays we are trying the e-prescription concept because how it will be helpful that with the e-prescription they have software where they will whenever the drugs, two drugs are prescribed in the interaction, some signal will be there. So in this way the prescriber will be can just avoid this drug interaction. So conclusion, to avoid adverse drug reaction, please seek a detailed drug history of the patient so that there there should not be drug interaction. And to mitigate the risk of we can mitigate this risk by the